Hi, this is the safety presentation for Group 2. We're going to be talking about the prevention of hospital-acquired pressure ulcers. A pressure ulcer is defined as any area of skin or underlying tissue that has been damaged by unrelieved pressure or pressure in combination with friction and shear. We know that pressure ulcers typically occur over bony prominences in immobilized patients and can be exacerbated by risk factors such as older age and increased moisture. It is estimated that 2.5 million people per year in the U.S. develop pressure injuries. In fact, 3.6% of all hospitalized patients develop pressure injuries. Even more shockingly, 7.9% of at risk patients will develop pressure sores. A pressure ulcer, on average, costs almost $40,000 per year, and in 2008, it's estimated that the care of pressure ulcers amounted in cost to $3.8 billion in the United States. It is also important to keep in mind that pressure ulcers in stages 3 and 4 are not typically covered by insurance, so those costs may not be included in this number. This is the article that we reviewed. It focuses on a program that was implemented in an ICU during 2013 that aimed to decrease the incidence of pressure ulcers compared to the 2 previous years. This study is a quasi-experimental design. There was no randomization or control groups, but there were interventions, which are procedures included in the prevention program for pressure ulcers. HAPU is just an abbreviation for hospital-acquired pressure ulcers. The interventions used in this program are listed on the slide. Pressure scores were used to indicate specific steps for proper management of moisture, nutrition, mobility, friction, and shear in hospitalized patients. Patients were at risk if their score was below 12, at moderate risk if it was between 13 and 14, and at regular risk it was 15 to 18. The revised skincare protocol was updated to include current recommendations by the National Pressure Ulcer Advisory Panel, which encouraged a more proactive approach to intervention well before any skin breakdown. These recommendations included fluidized repositioners, which are pads that would typically be placed behind the torso of all patients requiring repositioning and/or offloading, which would include any patients with a moderate risk on the Braden scale or a score of less than 14. They also included Aleven Life silicone adhesive dressings, which were also required for any patients with moderate risk, but were encouraged for all patients at vulnerable pressure points such as the sacrum, the heels, and the elbows. These dressings could stay on for 5 to 7 days and needed to be changed if they were soiled. The staff education was not a patient intervention, but it was still very important in ensuring the quality of patient care and to make sure that staff were following the protocol correctly and efficiently. Here are some numbers about the sample of the study. There were 563 patients included in the study, all of which were patients admitted into the ICU in 2013. This number increased from 461 total patients in 2011 and 434 in 2012. The mean patient age in 2011 was 51.9, 50.5 in 2012, and 52.2 in 2013. The percent of male patients in 2011 and 2013 was 59%, and in 2012 it was 64. These numbers, both in the mean patient age and the percent of male patients, are very similar, which helps to make the findings easier to compare between the years. One of the main findings of the study was that across all 3 years, the majority of pressure ulcers were stage 2. In 2011, 10% of patients developed pressure injuries, but in 2013, only 3% did, which was a significant decrease. We found it interesting that although the total number of patients admitted to the ICU increased in 2013, the researchers still met their goal of reducing incidence of HAPUs by 50%. In fact, the total decrease was 69%, so a little bit more than their goal of 50%. It was also interesting that the study discovered a 1.6% decrease in the incidence of HAPUs developed relating to medical devices. Unfortunately, none of the findings were statistically significant. However, the outcomes do have a lot of clinical significance economically and surrounding the care of patients. One of the greatest strengths that we found for the study was the emphasis on staff education and standardized implementation of the HAPU prevention protocol. This helped to keep the care of each patient standardized and helped to control potential confounding variables. We also thought that it was great that this study used multiple interventions to allow for maximum HAPU relief in patients. If one intervention didn't work, there were 3 others that could have an effect, which we think likely contributed to the decrease in total pressure ulcers. Finally, because the study utilized a quasi-experimental design, the effect of the interventions were observed in a real-life situation and not under artificial conditions. This allows for greater external validity, meaning the findings of the study can be better generalized to the clinical setting. The study also has more clinical significance because it was directly performed on patients in a hospital setting and it addressed a serious healthcare-related issue. Even though there was low statistical significance, the results still helped to show clinical significance because the interventions did help decrease pressure sore incidence by a significant amount, and it reduced costs as well. Some of the weaknesses that we identified are listed on this slide. It was not possible to record every step that the nurses took in their care of the patients, so therefore there's a risk for non-compliance in that the staff may not have always abided by the suggested prevention protocol perfectly. The study also used historical data as their control rather than hosting a control group. Because of this, the results could be skewed because the past years were not necessarily using or not using the interventions, so it's hard to say if the interventions are really what led to the decrease in pressure sore incidence. In comparison to 2011, before the implementation of this prevention program in 2013, the amount of pressure sores decreased markedly in 2012. This could have been the result of increased awareness and encouragement of the staff to be more proactive on the issue of HAPUs, but it decreases the significance of the findings in 2013 because, again, it's impossible to say if the outcomes resulted from the interventions. There were no inclusion or exclusion criteria listed other than that the subjects were those people that came through the doors of the ICU and took up those 14 beds in the unit. So this lack of inclusion or exclusion criteria does increase the external validity and the generalizability of the study, but subsequently it decreases the internal validity. And there were also no statistical data listed, so there's no level of significance or probability, which is a weakness to the study. As we've said, the study was conducted in a hospital setting by nurses, which makes it really clinically relevant because we know that the interventions are feasible to implement in a hospital setting and that they aren't too costly. However, we believe that much more research is needed because there were many weaknesses to the study and it's hard to fully understand if the interventions alone actually decrease the incidence of HAPUs. We do recommend that the interventions be used by nurses because not only are they in line with the National Pressure Ulcer Advisory Panel guidelines, they do show a decrease in pressure ulcer incidence, and we believe that these interventions could definitely have influenced that. So we wanted to reiterate that the study did not have a control group during 2013, and instead they retrospectively compared their intervention group with patients from previous years. What is the potential issue with this kind of comparative design study, and what would you suggest as an alternative design? Thanks for watching our presentation, and good luck with the question.